talk about before we get into barium enema is there are two exams that we didn't talk about last week in the small intestine. If you look on page 239, you see both of them. I have some experience with one, none with the other, and the one that I've never done before is what we refer to as a complete reflux examination. So that'd be a study of the small bowel through the colon. So it'd start with barium enema, and then we'd try to get some sort of reflux across the ileocecal valve to completely fill the small intestines. I've never seen that happen, not on purpose anyway. We had a patient who we were doing gastrograph enema on one time, and the ileocecal valve just didn't seal up at all, and it went all the way up into the patient's mouth. And that's disgusting. Yeah. And the patient started complaining about a foul taste in her mouth. I imagine you do. So I've never seen that in particular, but there is another exam. The small intestine is very difficult to get an air contrast study of the small intestine. You just really can't do it. If you have a patient drink the fizzies, the CO2 tablets, or put them in water and have them drink that, the gas pretty much stays in the patient's stomach. Some may get down into the small intestine, but it really doesn't give us a good double contrast exam of the small intestine. So we do a procedure called an enteroclassis, and it's a double contrast exam. And if you look on page 239, you can see in figure 15.88, the image of the enteroclassis is the villi, the contour, the mucosal lining of the small intestine. Actually, all three of those images is really pretty outstanding. And you just don't see that on small bowel series. So if we're looking for the mucosal lining on a small bowel series, specifically, they may order an enteroclassis, and you're only going to see a couple of these a year. We just don't see a whole lot of them. But they have developed some contrast that is kind of like a small bowel contrast that gives us a minimal amount of air contrast, and that will, a name brand example is what we refer to as EnteroView. So it's primarily barium based, but it has some other components in there that you pour the water in it and you mix it all up, and it gives us a little bit better of an examination than what a regular small bowel does, but it's not as good as a true enteroclassis. So enteroclassis, for your part for the enteroclassis, is to have the stuff available. And by stuff, what I mean is you have to have barium available, and you also have to have some stuff that's called methyl cellulose. And that's kind of a clear, yellowish, clear liquid that's real slick. And what they do is they put an NG tube into the patient, and it may be actually a duodenal tube, probably not a Dobhoff. If you're not familiar with what a Dobhoff is, eventually you will be. It's a feeding tube that goes into the small intestine. But it's got to be, the lumen or the hole going through it has to be big enough that the barium doesn't clog it up, right? So they put this thing through the stomach into the small intestine, and you'll use catheter tip syringes, and you'll just inject, you won't, but the radiologist or the PA will just inject in sequence the different medications. So you'll have two pans or two buckets of contrast. One will be methyl cellulose and one will be a barium solution. So they'll just take these cap tip syringes. Your job at this point is just keep those cap tip syringes filled up, right? So put your gloves on, because you're going to be putting it down into the bucket and sucking this stuff up into the syringe. And that methyl cellulose, like I say, gets really, really slick when it gets on the outside of the syringes. And it will, but they'll push some barium, and then they'll push some methyl cellulose, and then they'll push some barium and some methyl cellulose. And that's the exam that you get off of an enteroclassis, is those images where you can see the contours and the mucosal lining of the small intestine. So that's what that is. Enteroclassis, double contrast exam in small intestine. Really, the only true way to do that is through enteroclassis. Okay? So then we get into the large intestine, and we talk about the anatomy of the large intestine. We're going to talk a little bit about that today, more about that today. If you look on page 251, you see what I was referring to in a lot of cases, what we refer to as the different components of the large intestine. The description doesn't really follow, right? So if you look, especially at 15.110, that would be a double contrast study of the large intestine, and it looks like almost exactly half of our, maybe a little more than half of our transverse colon is actually vertical, right? So don't let the wording of those things, confuse you too much. It's still considered transverse colon, even though it's paralleling the descending colon on the patient's left-hand side. On the right-hand side of that image is still transverse colon, okay, even though it's very vertical, still transverse colon. So what we're going to do is we're going to do two different studies of large intestine. Excuse me. We're going to do a solid column, and then we're going to do the double contrast. All right, so the setup and patient preparation, we kind of ran through that before. Did we not? No, preparation is in this one. But the setup is really, I won't say extensive, but you want to prepare for contingencies, because what you've got is you've got a sick population of patients, and obviously they're having some GI issues, and with GI issue, you've had GI bugs, right? So with GI issues, sometimes you're going to have some complications, right? And complications in this case are the patient being an older population with less muscle tone than what they used to have. You may have a patient make a mess. So the patient preparation is going to be at least NPO after midnight, probably going to be a low residual diet, that last meal before the morning of the exam. And you may actually have the patient take some sort of laxatives and or enema. So you want the patient as cleaned out as possible, because small pieces of feces can simulate a polyp, and a polyp, of course now the patient's got a colonoscopy coming, and they're expecting to do a biopsy. So you want the patient as cleaned out as possible. So our first image would be a scout image. Keep in mind the size of your patient. If you have a hypersthenic patient, then you may, and you have like 14 by 17 inch image receptors, you may have to take two images for top and bottom. If you're working with a 16 by 16 image receptor, you probably get away with just opening your collimation to include the entire abdomen. But if you have a rectangular image receptor, you may have to do two. If you do two, what you're going to do is you're going to do one position like a pelvis. So you're going to put the top of the image receptor at the top of the crest, just like the pelvis. The second one, you're going to go with the bottom of the image receptor slightly below the top of the crest, so you get a little bit of overlap. That really does two things. It makes sure that you include all the anatomy, but at the same time, it accounts for the divergence of the central ray. If you position both of them directly at the crest, because of the divergence of the central ray, you might not include all the anatomy. So you get a little bit of overlap of the anatomy. All right, so patient preparation, we just talked about that. Maybe laxatives, maybe enema. It's going to be departmental and radiologists, their protocol. So also, though, what we want to do is we want to prioritize our patients. So we might have talked a little bit about this in upper GI and small bowel, but certainly in BEs where we're, in small bowel and BE, what we want to do is we want to prioritize our diabetic patients first, because they haven't eaten since, like maybe at least 12 hours before, probably more than that. So a couple of things. One is you want to put them first on the list, and usually older patients, but put them first on the list, but also have something available for them, some apple juice or some orange juice or something like that. And if they start getting a little bit goofy, you might consider giving them something to drink to bring their blood sugar back up. All right. Also, though, if you're doing a full barium workup on a patient, I might have mentioned this last week as well, we're going to prioritize our exams in a little bit of a different way. We'll start with a barium enema, and we'll fill the patient up. We'll shoot all the images, drain the patient completely out or as much as we can. Then we'll start with the esophagram, upper GI, small bowel follicle. Okay, and the reason for that is because if we have a patient drink enough to really fill the small intestine, then it's going to interfere with the images of the colon, right? So you've got a lot of barium inside of the patient all at one time. You just can't see the colon as well as what you would like to. Excuse me. So that will be our order of operation. Now, next week when we get into urinary exams and biliary exams, it's going to complicate things more than that. We've got to start with those exams before we get into the barium enema because it's iodinated contrast. So consider those things. We're going to talk about enema tip insertion. We'll talk about single contrast, double contrast exams. Double contrast, remember, is always going to be for the mucosal lining. And it may be a one-stage or two-stage procedure. Most of your, well, I'll just say every hospital I've ever worked in used an enema bag that eliminated the need to do the two-stage procedure. It's just one-stage procedure. You put some contrast into the patient, some barium into the patient, and then you put the air into the patient. That sounds like two-stage, but it's really not. What two-stage is referring to is you put barium into the patient, drain the barium out, and then you put air into the patient. That's your two-stage procedure. But the equipment we use enables you to do both of those with one move, so to speak. So your contrast media, you've got two different types, and in a lot of cases this depends on whether you're doing single contrast or double contrast. Single contrast exams, in my experience, the barium it comes to you loaded in the bag and you just add water. The air contrast, though, you would empty out of it's about a half-gallon bucket, or a half-gallon bucket, not pitcher, that's not the word I'm looking for either. It's kind of like a jar. English is just not coming to me today. So, be familiar with your stuff, and you're going to have a tendency to think, okay, well, I'm going to be putting this stuff into the patient. If I put it into the patient at their body temperature, it's going to be easier for the patient. That's common sense, right? Well, common sense doesn't always work for us. What happens is if you put warm barium into the patient, it has a tendency to make the bowel spasm, okay? So anything that you can do to relax the bowel, the better off you are. And oddly enough, cool water does that. So I've worked in hospitals where they took those jugs, that's the word I was looking for. Yeah, complicated word that, jugs. Where they took those jugs of water, they actually kept them in the refrigerator for that reason. So if you're mixing the barium up, right, if you're mixing it up and you're using tap water, resist the urge to use warm water. Just use cool water. It relaxes the bowel, and again, these are older patients. Muscle tone is not what it used to be. They may lose the enema tip and make a mess. So you want to do whatever you can to relax the bowel and improve the chances that you get a good exam for the patient. So contrast media, air contrast, double contrast, the air provides that double contrast. I've never worked anywhere where we've used carbon dioxide. I suppose you could. It absorbs better, but I've just never seen that happen before. So if you find yourself in a hospital that uses carbon dioxide, great. I've just never seen it ever before. All right, so we've talked about that already. We've really talked about that. So BE apparatus, and what I'm talking about in the BE apparatus is the equipment that you're going to use. I'm going to show you some pictures, and there's some in Merrill's that you can look at, and you can differentiate between the type of bags that you will be using for air contrast versus solid column. And I'll show you how to spot those. So You may need to have some smaller enema tips available for, some of your pediatric patients. You're gonna have to use different enema tips if the patient has a colostomy or something like that, so that, you may not be able to use a regular barium enema tip. You may have to use something like a Foley catheter or something like that for that. Some sort of specialized enema tip for those colostomies. So what you're gonna have, let me go ahead and get to this and explain the different portions of this. So what you've got here in an enema tip is a number of different things. So this middle port right here is what you would use, what you would plug the tubing in, and I know the picture's not, it's kind of grainy, and this is gonna make it worse, but it's kind of grainy. But that middle port there is what you would attach the tubing that comes from the enema bag to. So that's where the barium is gonna flow. But you notice you've got two more things coming off of this. And this one here is, you would connect that to what we refer to as an inflation cuff. And the ones that I'm most familiar with are just these little square things. And what they are is a single squeeze balloon inflator. So this area right here is, you can't really see it, but it's got a little balloon in it. All right, so it's kind of clamped off here and clamped off there, so it can't move. And you would connect your inflator cuff to this, and you squeeze it one time, usually one time, and that balloon will inflate. Now once we get the balloon inside of the patient, if we fill the patient up completely with barium, and we just have this enema tip inside of the patient, you're gonna have a mess, right? So the purpose for that is to hold it inside of the colon. We'll talk a little bit more about that and the importance of having that in the right place before you inflate it, but that's what this thing is. Now, that inflator cuff also should have a clamp that comes with it that you would slide. So you'd inflate the balloon, and then you'd slide the clamp across the tubing to make sure that it doesn't de-inflate. I always used hemostats too, because I just didn't want the thing to deflate. So, use hemostats if you feel like it, or you can trust that little clamp. Either way, it's up to you, entirely up to you. This other one, this big blue one, is for the air, if you're doing air contrast. So if you're doing solid column, you're just gonna have these two things coming off of it. If you're doing air contrast, you're gonna have three coming off of it. Okay, so that's the enema tip difference between those two. Three for air, and this is gonna have, generally, I know blood pressure is usually, just a little machine, they push the button, but if you've ever had your blood pressure taken where they actually inflated the cuff by squeezing this little balloon, that's what this thing looks like. So you put this, and it's usually blue, so you put this little squeeze ball onto the end of this, and that's how they would inflate the colon, really, in this case, to introduce air into the colon, okay? So 3 hoses or 3 tubes coming off, 3 ports coming off for double contrast, just 2 for single contrast, right? We don't need this one, the blue one, for single contrast. So that's your BE apparatus, and you've got the bag, and you've got the barium, be it premix, add water or whatever. Okay, so make sure that you know what kind of exam you're doing, so you know which type of balloon or which type of enema tip and what all you need to go with that enema tip. Double contrast, you need that one. Also, look around and see if your hospital uses these. A lot of people call this a kiddie pool. And what it is a retention ring. And most hospitals don't order these. If you find yourself in a position where you can influence the ordering of supplies, these things are great, fantastic. And what you do is you put that under the patient's hips so that, if they lose some of the barium, it's contained there. The problem with barium enema is, number one, if the patient loses the enema tip, and it happens, If they lose an enema tip, barium goes all over the place, and it can get underneath the table. It can get inside of the pad the patient's laying on, and then the pad is trash because you've got an artifact you can't get rid of, and it's going to show up on every x-ray you take after that. If it gets inside of the table, it gets on top of the x-ray tube, then you got to tear the entire table apart and clean that off. Otherwise, for every fluoro exam, you're going to have an artifact. So these kind of help to contain that. I've only worked in one hospital routinely, ordered these, and part of the reason was I was in charge of ordering for a while. So I stocked up on these things. So what you do is you put these under the patient before you inflate it. Notice though that the inflation tubing is very small. You can use O2 tubing on the wall to inflate that. It does very, very good. You just stuff it on there, crank the O2 tubing up, or the O2 regulator up to 10, and it'll inflate it with the patient laying on top of it. Okay? It's short. Don't get down there and try to blow the thing up by mouth. Use O2 tubing. Don't be weird. So if you're working in a hospital, and again, most of your hospital is not going to have that. If you don't have one of those, then make sure you have plenty of towels. And what you're going to do is pretty much do the same thing as what you would do with that. You build a levee underneath the patient's thighs that comes up to their hips, essentially. Because again, your patient may lose barium. Also, for your own protection, you want to make sure you wear real shoes. If you wear Crocs, they should be solid on top. If you're wearing canvas top shoes, I really recommend you buy leather. Leather repels fluids a whole lot better than what the canvas does. If you're wearing those canvas top shoes and that comes out of the patient and it drips onto your feet, it's going to be nasty, right? So wear real shoes. So we talked about preparation of the suspension. Most of the time it's going to be 1 to 2 liters of barium. Just more of the same stuff. So make sure that you explain the exam to the patient. For some reason, your patient sometimes will come in and they'll think that because they're going to x-ray, that enema has a different meaning, and it does not. We're going to give them an enema, just like any other enema they may have. We're going to roll them around into different positions and take x-rays. So prepare your patient mentally, explain to them what's going to be going on. If the patient's already complaining of stomach cramps, then they can give them some medication to help with that. So, get your patient history and present it to the radiologist or whoever's doing the exam to try to make it a little less unpleasant for the patient. All right, so just more of the same stuff, all the steps and whatnot. So the enema tip insertion is going to be in a specific body position. So what you're going to do is you're going to have the patient roll up onto their side, put their left arm down to their side, and have them roll into an LAO position. And with that LAO position, you're going to bring the right leg, in front of the patient. So that way, the patient's in a kind of a stable spot, stable position. Remember Sims position. That's the only place that you're going to hear that referred to as Sims position. LAO position, Sims position. And then, sometimes it takes a little bit of adjusting of the angulation of the enema tip to get it get it started and then get it going in just right. Remember, we've got the sigmoid colon and the rectum comes down. It makes a pretty sharp angulation. So sometimes it takes a little bit of manipulation to try to get it going in the right direction. Don't force it. Have the patient take in a big deep breath and slowly blow it out. And then when you know that you're in far enough, is the enema tip, the body will take the enema tip away from you, essentially. Okay, if you've not seen any x-rays, they're just go to weird x-rays, you know, do Google search for weird x-rays, and you will see a lot of stuff of things lost in body cavities, right? That's because of this, is that you get something into the rectum so far, and the body will take it away from you. Okay, it'll start to pull it. It's like a negative vacuum like a vacuum that pulls it away from you. Okay, so once it does that, then really it's in far enough to inflate that cuff. If you just put it in and it does not take it away from you, and you inflate that cuff, what you're doing is you're inflating it right at the sphincter, and that's going to be painful for the patient. You don't want to do that. Okay, so make sure that it takes it before you inflate. Some of your radiologists and your PA, they prefer for you to wait until they get into the room. They want to inflate under fluoroscopy, and for good reason, because a lot of your colon cancers are going to be in the rectosigmoid area. So if they already have a weakened colon and you inflate that balloon, potentially you could cause some damage, right? So a lot of your radiologists they want you to put the enema tip in, but they don't want you to inflate it until they get into the room. Okay? So Sims position, big deep breath, may take a little manipulation to find the right angulation. Push it until it starts to pull it, and then you should be good. So you want the IV pole no higher than 24 inches above the tabletop, and the reason for that is, again, you may have some weakened areas in the bowel. It's kind of like a water tower. You know, the way a water tower works is that you put enough water up into the water tower, you pump water up into the water tower, and then you can turn pumps off, right? So the water is way up in the air, and all that pressure is pushing down through the pipe where the water is going to come through to come to your house, right? Well, kind of the same principle here is if you happen to live close to a water tower, your water pressure is just through the roof, and you've got some really good water pressure. So the higher the water tower is, the higher the water pressure is. And in the same way, the higher that enema bag is, the higher the water pressure, the pressure on the barium is going to be. So if the patient has a cancer, or if they've got diverticulitis or something that's weakening the wall of the colon, and you put that thing at 36 inches, again, you might have a problem. You could cause damage to the patient's colon. So no more than 24 inches. That's a common registry question, so you want to hang on to that. Are you going to take out a tape measure every time and measure the height? And the answer is no. You know, you come walking in and the enema bag is close to the ceiling. You know that's a problem, right? Just lower it down, kind of get a visual of what your techs are doing, and they're probably getting pretty close to 24 inches in most cases. So that's the purpose for that 24-inch thing. Again, common registry question, so you need to file that away, even though you're not going to measure it, you need to file that away. So especially if you're doing a solid column, you want to run, before you put the enema tip into the patient, you want to try to purge the line of all the air. So what you're going to have are these little slide clips that turn the barium on and off. So what you want to do is you want to fill the bag with barium, and then you want to open that up very slowly until you bleed the line of as much air as you possibly can. All right, so you're going to want to do it on both air contrast and solid column. Probably a little more important to get most of it out on solid column than what it is on air contrast, because you're going to be putting air into the patient anyway. So we just talked about all that. Tip of insertion, single contrast. So once you get everything set up, you get your little levee built. Again, more important probably with older patients than younger patients. You go and get the radiologist. Radiologist comes in. You introduce the patient. And first off, make sure you cover the patient up. You got the patient in a Sims position. Patient has to be exposed, right, for you to put the barium enema tip in. But as soon as you get it in, have the patient lay back, flat on their back, and keep them covered up with a sheet, right? I always told my students when I was clinical instructor over at ETMC, if I ever walk in and a patient's still in the SIMS position, you know, and the enema tip's in, and you've gone to get the radiologist, that's going to be your last day in clinicals. You know, I mean, this is an embarrassing exam for the patients. Don't make it worse. You know, keep the patient covered up. All right, so at this point, once the radiologist or PA gets into the room, your job at that point is assistance, right? So your main job is turn the barium on, turn the barium off, and that's pretty much what the radiologist is going to say, barium on, barium off. So when he says barium on, then you just slide that clip, barium fills the patient's body, and the radiologist says barium off, rotates the patient around, barium on, you turn it back on. Your other job at that point is, again, to keep the patient covered. So the radiologist says, okay, I want you to rotate up onto your left-hand side. When you roll over at night, what happens to the sheets? They go with you. You get wrapped up in the sheets, right? Well, the same thing happens with the patient. So when a radiologist says, you know, roll up onto your left-hand side, you're going to grab the sheets, you're going to lift them just a little bit so the patient doesn't expose themselves, right? So those are your two main jobs at that point. Patient, the radiologist fills the patient up, you keep the patient, or the radiologist runs fluoroscopy, you run the barium and keep the patient covered up real bit. So then, as the patient's rolling around, the radiologist rolling the patient around, they're going to be taking overheads, or they're going to be taking spot films. And they'll take spot films usually of the flexures, sigmoid colon, descending colon, ascending. They'll take spot films of everything. So they will take the overheads, or they'll take those spot films, and on their way out the door, again, you're going to ask them, do you want any overheads? And at that point, they may give you just a few, you know, based on what they saw while they were fluoroing, or they may say, yeah, full series. We're going to cover full series, okay? So the difference between air contrast and solid column BE is everything that we do in solid column, we're going to do in air contrast, but with air contrast, we're going to do everything we did in solid column, only in reverse as well, okay? What I mean by that is if we do an AP on solid, we're going to do an AP on air contrast, but we're also going to do PA. Now we'll walk through why we do that. If we do an LPO, we're going to do the exact opposite of that, which is a RAO, right? Okay? So we're going to do everything that we do on a single contrast. Everything we do on a single contrast, we're going to do on double contrast. Plus, we're going to do the exact opposite of it as well. Okay? So we're going to shoot those overheads, and then we're going to assist the patient to the bathroom. The last image that we're going to take is what we refer to as a post-evac film. So we take the patient to the bathroom, and there's different ways that you can accomplish this. You know, the patient's going to go and evacuate the bowels. So you may see technologists just push the biohazard box or bag or trash can or whatever over and take the enema bag and put it inside of the biohazard and just have the patient drain directly into that. Leaving the enema tip fully inflated, just drain the patient that way. Okay, before I get too deep into this, I'm not saying that any one of these is right or wrong. I've used all of these. So you may see that. They drain the patient that way, then deflate the inflation cuff, remove the enema tip, and then have the patient go to the bathroom. Okay, and then you come back and you shoot your post-evac. So that's one option. One option is to deflate the inflation cuff, pull the enema tip with patients still retaining all that barium, and have them try to squeeze and get to the bathroom. May be very difficult for the patient. You may have a lot of cleanup that way. That may be your protocol. And the other would be to walk the patient to the bathroom with the enema tip in place, remove the enema tip when you get the patient to the bathroom. That's just embarrassing for everybody. but that might be your protocol as well. So, those are the three means of getting the patient to the bathroom, getting to the post-evac, get the patient back up onto the table, and post-evac is just KUB. So first image is going to be a scout, last image is going to be post-evac, and now we're going to talk about all the images in between. Okay? So for single contrast, this is what we're going to do. We're going to do an AP, an LPO, an RPO, some sort of AP axial. Our local protocol is to do an AP oblique axial. You just don't find that on the internet all that much. The other textbook, the Bontrager's, actually has images in it. The video online actually shows that image. But I've only worked in one hospital, one group of radiologists, that's the teleradiologist, that actually did the LPO sigmoid. I've heard it referred to as butterfly view. You could spend all day searching for that. You're just not going to find it all that well. So you're going to do all those. You're also going to do a lateral and then your post-evac. So your lateral may come with some variations as well. All right. Oof, that could have been expensive. So your lateral, some of your radiologists will have you rotate the patient up onto their side, remove the enema, just shoot a lateral that way. Some of them will have you shoot the lateral with enema tip removed, in which case now you're going to have the patient do that squeeze walk to the restroom. They may have you do a cross table lateral with the enema tip removed. Okay, so there's some variations. Each one of those has some legitimate reasons for doing it. In each case, what you're going to see there that's different from any of the other ones is you're going to see the retro. What does retro mean? Yeah, back. Yeah, something from way back when. Right? Retrorectal space is what you're looking for there in each one of those. But again, a lot of your cancer is rectosigmoid area, and it's best seen with, some sort of lateral with the enema tip out. And then you're going to bring the patient back for a post-evac. So we're going to do kind of the housekeeping on this, and then I'm going to show you the images, or the what you see on each one of the images. Okay. So, Welland method, never done. Double contrast. That's all that. Double contrast we'll talk about here in a minute. So, with the AP and the PA projections, we're just going to focus on AP right now because it's solid column. So what we're going to do is we're going to position just like KUB. Again, if you have rectangular image receptors, you may need to do two. You may need to do the one that looks like the pelvis, and one, where the bottom of the image receptor is below the iliac crest. I would even go so far as to say that once you get the colon full, even somebody who's sthenic, you might consider doing this. Just because once you get it all full, the lateral side of both the ascending and descending colon may be projected off the image receptor. So, it might be a good idea for sthenic and hypersthenic to go ahead and do two crosswise. For your asthenic and your sthenic patients, you probably won't have to. So, but for the most part, you're going to position at the iliac crest. All right, that's your textbook positioning. Also, textbook answer on the registry or on our test is hypersthenic patients. What are you going to do? Two crosswise, right? Okay. So what you want to see is no rotation, blah blah blah, just like KUB. And this is a double contrast exam. So we're going to back up, and we'll look back at these here in a bit. But this is double contrast, and just like a KUB, what you want to see is no rotation, so you can look at the pelvis, make sure that you have no rotation. If you can see the spinous processes in the center of the vertebra, like right here, you can see it. You can tell you that you have no rotation, and also the ribs you can look at. So what you want to see is you want to see the entire colon. So that, nothing special on the AP or the PA. This patient does have a couple of diverticula. You see these little things here? That's what diverticula look like. Sometimes your patient, that's one too. Okay, so now this is a good example of why it is we can see, or why we do double contrast. If the colon was completely filled up with barium and we didn't have any kind of air contrast, you would be able to see that. Okay, so these are enough to say that this patient has diverticula, right? But what if none of those were there and that was the only thing that we could see? Couldn't make that diagnosis. What if that wasn't even a diverticula? What if that was some sort of filling defect that was pushing into the lumen of the bowel, like a polyp that would look like a cancer, right? So double contrast, that's what it shows you, all right? And it's also a better looking image. I always thought double contrast was, as opposed to a solid column, a very interesting looking study. All right, so the AP and PA just show the entire colon with air contrast. Of course, we can see the other stuff as well. So we're going to skip past PA axial because we're not doing PAs just yet. RAs, LAs. Okay, so AP axial, we are going to do that. Okay, well, whether you do the AP axial or the LPO sigmoid, AP axial, LPO sigmoid, is up to your departmental protocol. Again, with the Tyler doctors, you don't do the AP axial, you just do the LPO sigmoid, or at least that's the way it was last time I was in practice at ATMC, which is now UT. So you wouldn't have to do both, but the positioning is really pretty much the same, or the central ray angulation is pretty much the same. So what you're going to do is you're going to angle 30 to 40 degrees cephalic, and you're going to enter at the inferior margin of the symphysis pubis, but are you going to palpate the symphysis? Do not recommend it, right? So do not recommend it. So remember that the distance between the symphysis pubis and the ASIS, it's about 4 inches, right? Or you can go with the greater trochanters to localize the hips. The hips are going to be pretty much the same location as the symphysis pubis. So you got telltale indicators of where to go, right? It does show that the field should be 14 by 17. That's probably a little excessive considering we're just looking for the sigmoid and the rectum and anus, all right? So collimate down. I think that's kind of excessive. I think that Merrill's really should edit that for the next edition. All right, so what we see then is this. Again, we're going to have a lot of superimposition anyway, but it's the best view that we're going to see of this area just to kind of straighten it out a little bit. Okay, so that just describes LPO. All right, so your obliques, you're going to do 2 obliques. You're going to do LPO and you're going to do an RPO. Again, we're still on solid column. So in both cases, they're going to be 35 to 45 degrees. And what you're going to see then is, I usually use a high voltage cable. I left it down in my office. So I'm going to use this instead. So this patient has a massive appendix. If I'm going to make that appendix, I got to put it on the proper side. Now, the reason I like to use high voltage cable is it's not as flexible. It's not as much work to get it to cooperate. There we go. All right. Okay. So the colon, we have a tendency based on the description to think of the colon as coming straight up, going straight across, and going straight down to the sigmoid, right? It doesn't really do that. It goes, we have the cecum, as again is my appendix, right? So this is the appendix hanging off the bottom of the cecum. The cecum is the first portion of large intestine. So the ileocecal valve would be like right about here. And then we've got the ascending colon because it comes up, and then we've got the transverse colon because it goes across, and then we've got the descending colon because it goes down, and then we've got the sigmoid colon because it's kind of in a weird way S-shaped. So with the obliques, be they PA or AP, PA once we get to air contrast, we're going to see specific things. So looking at the shadow, first off, it also does not just come up and go straight across. Remember your hepatic flexure, your right colic flexure, we'll be using those terms interchangeably. They mean the same thing. Your liver is sitting right here. Liver being the largest organ is going to have a tendency to push that right colic flexure lower than the left colic flexure, okay? So you're never going to have straight transverse. It's always going to be a little bit of an angulation, but also what's going to happen is the transverse colon, that part right there, is going to be anterior, okay? So it comes up, it makes a turn to go across the patient's body, but at the same time it makes a turn to go anterior. It goes across the patient's body. When it gets to the other side, it turns and it goes down, but it also turns and it comes backwards as well. So in a straight AP, what we get is it's like trying to straighten out a spaghetti noodle. What we get is superimposition. You just can't see the flexures very well. Okay, can everybody see the shadow pretty good?
Your head's a little in the way. Not that you got a big head, but.
Okay, we're not talking about the appendix here.
Okay,
that's up here we're looking at. All right, so everybody's a critic. So watch what happens when oblique. Okay, remember we're doing anterior oblique, or we're doing posterior obliques rather. So we're doing AP obliques. So you're kind of suspended from the ceiling here, right? And I'm laying flat on my back. So this is anterior, right? So as I rotate up, what happens to now I'm in an LPO position. What happens to my splenic flexure? Does it get better or does it get worse? Do we have more superimposition on the shadow? Or do we have less? It's a mess, right? So we've got the whole thing kind of wrapped around itself. But what happened on this side? Now I can put that big fat head all the way through the flexure, right? Right?
Yeah.
Okay. So what do you suppose we're interested in seeing in the LPO? The one that became a mess or the one that became open? Open. So LPO, in our posterior obliques, LPO and RPO, what we're interested in seeing is the open flexure on the elevated side. On the upside, that's what we're going to be seeing. So LPO is going to show us our right colic flexure, right? RPO then is going to show us what? Left colic flexure, right? So always the elevated side. Now when we get into air contrast, it gets a little bit more complicated. We're going to have to consider it a little bit more, but that's still what we're going to be seeing. Okay? Got it? So AP obliques, elevated side, all the time. 35, 45 degrees. All right, so your textbook is going to say that what you need to do is you need to center at the crest. But what is it that we're looking for on the obliques?
They're called flexures.
The top, the flexures, right? So what I'm going to tell you in a practical sense, and some of the images in the textbook, I think both textbooks, show where on the obliques the flexures are clipped, right? Again, they really should consult me before putting it in the book. I'll tell them what they did wrong. You want to make sure you get the flexures, right? So where are the flexures? Especially the splenic flexure. Really, really high, right? So should you center always at the crest for your obliques? I never center at the crest for obliques. You're probably going to be about 2 fingers width above the crest, because what I want to see are the flexures, right? You center at the crest, you miss the flexure, and your image just isn't any good, right? So textbook positioning, center at the crest. When you start doing these,
if you start doing these. Center a little bit above the crest, only for the obliques. Okay? Now the other thing, the other little tip here is, so what are we doing? For our routine, what are we doing? And the orientation and the demonstration of these, I left it kind of this mess up here just to make this point specifically. I know some of y'all may be thinking, no, you didn't. Yeah, I actually did. Okay, so you got AP, LPO, RPO, or I'm sorry, LPO, RPO, APA sigmoid colon, which is going to be your LPO sigmoid here in Tyler. Then you got your lateral. Okay, so let's follow this out. What have you done to the patient at this point? You're going to turn them. The radiologist already turned them. But what did you do before you did that? You fill them up, full of fluid, right? And even if you did cool fluid, it's still not comfortable for the patient. What's your patient population most of the time? Older patients with, they've lost some muscle mass, right? So let's follow, we're not going to go back through the images or the slides, but let's just follow this, okay? So what are we going to do? First one, we're going to do what? AP. All right, so we're good. And then we're going to do what? LPO, right? So then we're going to do what? RPO, right? And then we're going to do what? LPO sigmoid. And then maybe lateral. It might be a prone lateral, right? Is that efficient? It's not terrible, but is it the most efficient you could do? The answer is no, right? So what could you do to make that more efficient? More efficient. Let's say that our routine is to shoot a lateral rectum on the table with the patient on their side, just to make it simple. What would be the best way to go about this with moving the patient the least? How about AP, RPO, LPO, LPO sigmoid, left lateral, right? You start rolling the patient around more and more, you increase the chance the patient's going to lose the enema tip, the balloon, right? So now consider, and we're going to take a break before we get into double contrast, but now consider we're doing all of that plus the exact opposites, right? So you do your AP, you do your PA, you do your LPO, and then you do your RAO, and then you do your LAO, and then your RPO. Come on, So write it all down. When you start doing these, write it all down, a logical order, and make an image, look at your order, scratch it off, make the next image, scratch it off, okay? And make it the flow as simple as possible. So any questions on that? No?